Beautiful afternoon, and I know people are going to keep joining, but I think we should get started. I really wanted to thank Dr. Lepley for his collaboration on multiple initiatives that we have through our opioid use disorder work group, and it's just been a friend and colleague, and really somebody who was at one of our first launches 4 years ago in person. And has really continued to keep us abreast of what he's up to, and how we can all learn from each other. So I had a little preview of this presentation, but I'm really excited for him to share. I think his conceiving of this program and implementation of this program in LG and mobile addiction treatment in primary care offices. So go ahead, John. Thank you.
Yeah, thank you. Thank you for the opportunity. I first connected with Penn when I was a jail doctor. I got invited to the Cherish conference. I don't know how, but I really met so many bright people. So it's really a great opportunity to now come full circle and be here and sharing something, some of my work with so many bright people in attendance. So thanks for the opportunity. This is just to help people learn a little bit more about myself. I've been a physician for about 20 years. I'm board certified in family medicine and addiction medicine. I worked most of my career in the Philadelphia jail system, so I still remain very interested in improving the health of people who are incarcerated. I'm president of the American Osteopathic Academy of Addiction Medicine. As the name implies, it's a bit of a niche organization, but we're comprised of about 1,000 osteopathic physicians across the United States, mostly working in rural, underserved parts of the country. So I do get a viewpoint of what addiction treatment is like in a lot of different places across the United States. Anyone's welcome to join the AOAAM. You don't have to be a DO. Also, for the past 6 years, I've been on an advisory committee for the Pennsylvania Physician Health Program, and I chaired that committee for the past 2 years. So I have very varied experience that I bring to this presentation. I don't receive any compensation from pharmaceutical companies, never have. This slide is to introduce everyone to LG Health, because I don't know how much we know about each other. Lancaster General Health has a very important legacy in Lancaster County. Lancaster General Hospital, pictured here, has been in existence for 130 years. We're the largest employer in our county by a wide margin. One of the most important things that I do is I spend 45 minutes with people at new employee orientation. Being the largest employer in the county, I think that's a really good way to impact the community and improve the culture of the community and their approach to people who use drugs. We merged with Penn in 2015. Lancaster General Hospital, I think, is about 650 beds. Don't hold me to that. We also have a separate women and babies hospital. We have a separate physical medicine and rehabilitation hospital. We have 34 primary care practices and 31 specialty practices. One disadvantage of a large organization is silos. We're in our silo. It's in behavioral health. We reside in the behavioral health service line alongside psychiatry, and we have a large integrated counseling department. Addiction medicine and integrated counseling, a lot of that work is done in primary care. So although our cost centers are in silos, the work we do is very much in family and community medicine. And we have a direct patient care model that I'll talk about, and our care managers, who are all licensed social workers, do most of their work in primary care. Everything I talk about today is a very small team. We currently have 10 people on our team, one manager who helps keep us all together, one customer support specialist who answers the phones. We have 2 nurses, 3 providers, but 2 FTEs, since some of us work part-time in addiction, part-time in family medicine. And then we have 3 social workers. We call them care managers. Before I came to LG Health, most of the 2010s I spent working in the Philadelphia jail system. We started prescribing buprenorphine to people with untreated opioid use disorder far before there was a sense of urgency like you see today. I think this article is from 2018. It was so unusual back then to prescribe buprenorphine in a jail that the Philadelphia Inquirer wanted to do a news story about it. when this reporter, Aubrey Whelan, asked me, why is it important to prescribe buprenorphine to people in jail? I think I said it's important so that we can preserve people's tolerance to opioids so they don't have an overdose when they return to using drugs when they leave. That is a good reason to prescribe buprenorphine. Thankfully, this woman you can't really see off to the left, she had a much more optimistic thing to say that they published. And it was how important this medicine was to her and how it really gave her hope in an environment that was really hopeless for so long for her. That was a really important day for me because I got to hear many people describe things like that. And the only thing we did for them in the jail was give them a single tablet of buprenorphine, 8 milligrams. We could not individualize treatment. We could not provide individualized medication management because there's simply way too many people in jail with this problem. In the Philadelphia jail, when someone came in, we tried to see them as soon as possible. They got 4 milligrams of Subutex and then 8 milligrams later that day and every day after that. And then they were seen again at day 30 and every 90 days. That's a terrible way to provide buprenorphine, but it's also the only way. In the community, the National Survey on Drug Use and Health says the prevalence of opioid use disorder is about 2% to 2.5%. But in jail, it's about 20 to 25%. So at the Philadelphia jail, where they do about 25,000 intakes per year, you're looking at around 5,000 people coming in per year with an untreated opioid use disorder. That's about 17 new patients every day. In a facility that houses 6,000 people. So it is worthwhile to consider your practice setting and how you would adapt to treat 17 new people every day, Monday through Friday, and then still provide responsible medication management to all of them. I learned about mobile treatment when trying to solve that problem. I looked at what other jails do, and I found that none of them really know how to solve that problem. I still think there's no solution. Mass incarceration is an unsolvable problem from our perspective. But what they did in Baltimore was this community treatment provider would park this mobile treatment van outside of the Baltimore jail. This image is from an article in the New England Journal of Medicine published in 2020. And people would leave jail and connect with this van where they'd be offered buprenorphine treatment. It's unusual to see a van parked in the middle of the city providing buprenorphine treatment, but what occurs inside the van actually should look very familiar to primary care providers. It's called a low barrier models or low barrier buprenorphine treatment. Off to the right here, these are some tenets of low barrier treatment. Provide a welcoming environment for people. Prescribe medication as soon as it is clinically indicated and desired by the patient. Individualize the dose and appointment frequency, and most importantly, don't withdraw medication during episodes of disease exacerbation. That's all very familiar. That's how we treat all health conditions. Unfortunately, historically, it's not how we treat opioid use disorder. Maybe this is a controversial slide, I don't know. All these bullet points I derived from old medication agreements at LG Health and medication agreements that I found through ASAM, the AOAAM, and the PCSS. This is the very conventional way of treating opioid use disorder with buprenorphine. It involves doing a urine drug test at every visit, having an arbitrary cap on the dose of buprenorphine, usually 16 milligrams per day, one size fits all visit frequency. It's very common to say that people may be required to provide an observed urine. People may be required to come back and perform random medication counts. Some of these bullet points I took off of old medication agreements in Lancaster, and I was really struck by the way the phrase failure to report appeared over and over again, that if people failed to report changes to us, they could be dismissed from care. And what struck me about that is how it really puts the clinician in the role of a policeman or a probation officer. And something I hear from patients and honestly providers frequently, not so much anymore, but certainly a couple of years ago, was this notion of 3 strikes and you're out, meaning 3 unexpected findings on a urine drug test and you're dismissed from care. And that they say 3 strikes and you're out speaks to the lack of guidance that clinicians receive on how to use urine drug testing. We are looking to the sport of baseball to guide our approach. Prior to 2017 at Lancaster General Health, there was really only 1 or 2 practices. There was a place called Comprehensive Care Medicine that was providing buprenorphine treatment on Tuesday afternoons. And then pictured here is Twin Rose Family Medicine. They were early adopters of buprenorphine treatment. I haven't been with the organization long enough to know when Twin Rose joined, but these are some providers from Twin Rose, and they have a long legacy of early adoption of this treatment. When LG Health got a Center of Excellence grant in 2017, some champions of it for addiction treatment, Dr. Tawil, Adam Lake, Beth Freeman was somebody who was here, was very crucial to really spreading the word on the importance of providing buprenorphine treatment and providing a lot of waiver trainings. And a lot of our social workers were really key in connecting people to these practices who had this training and really spreading the word on the importance of treating addiction in primary care. Within 2 years, we went from 2 practices to about 11, and we were treating about 343 people.
Red is bad though.
What-
Why?
A couple people need to
Red.
just mute their microphones, please.
So I just want to say this was very effective. If you did nothing but just found practices, train them to prescribe buprenorphine, you can have a really big impact in your health system and your community. And you'll see in later slides, it was very impactful at reducing overdose deaths in our community. These are all the practices that were doing this work early on, even before I arrived here. There was a very good foundation. And I was very impressed by all the work that was being done already. When we looked at opportunities for improvement, we saw that it was hard for people to get an appointment within a week. It was actually hard to get that first appointment. And we found that a lot of patients didn't stay on the medication for a year or more. Of all the patients being treated, it was less than 40% that filled a prescription for at least 10 out of the last 12 months. And 343 patients is pretty good, but still relatively small considering the size of our health system, and our service area comprises about 1 million residents in South Central Pennsylvania. Some reasons for poor access. Difficulty getting a new patient appointment in primary care is difficult everywhere for any reason, let alone finding someone who also is willing to prescribe Suboxone treatment. The average wait time for a primary care appointment is 3 weeks. I would guess it's much longer in our health system based on my observations. There also, the intake process, though well-meaning, was somewhat fragmented. A patient would call one of our care coordinators who would gather information about the patient and then go to the practice to try to get them an appointment. Sometimes the practice would come back and ask them for more information. And the care coordinator, the social worker, whoever that person may be, became an inadvertent gatekeeper of medication, when really the ideal is the patient gets right in front of the provider and the social worker should be alongside them, not in between them. We did see a lot of hesitation and problems with prescriber confidence. Not everyone felt comfortable providing Suboxone treatment, particularly if the patient was reporting use of other substances like cocaine, methamphetamine, or even cannabis in some cases. A very common refrain was, I think this patient needs a higher level of care. Anytime I hear that, usually what the patient needs is low barrier care, which is still labor intensive sometimes, but usually higher level of care is a euphemism for somebody needing lower barrier care. And there was really poor awareness that LGL offered this treatment. A lot of patients called our care coordinators through word of mouth. They got the phone number from a friend. Here's our service area. We serve almost 1 million people. Our primary service area is central Lancaster, but we have a pretty broad reach. We have 34 primary care practices. All these blue dots are primary care practices at Lancaster General Health. When I talk about mobile treatment and the concept of mobile treatment, we think that we're going to be serving the areas in between these blue dots to overcome transportation barriers. And that would make a lot of sense, except 2/3 of these blue dots are places where buprenorphine treatment's not available at all. So if you're going to do mobile treatment, a really good starting point is the family medicine practices themselves. So when we wanted to expand our reach and improve access, we didn't feel as though we needed an RV. We just, instead of parking outside the practices, these places are very nice. They let us in the building, and we worked with them to get credentialed in these practices and to share space. And our typical ask was 2 exam rooms and to have the front desk staff register our patients. But we would bring our own nurse, our own provider, and our own social worker. At one point, we were at 9 different locations, usually for 4 hours per week. So a different location for 4 hours every day of the week. Our team consisted of a provider, a nurse, and a social worker, one of our care managers. And then we had one person at the time, she was called a resource coordinator. Now her title is customer support specialist, but one person answering the phone who managed our schedule and put patients on that schedule. You did not have to be a patient of LG Health to get an appointment with us. You just had to need help. So anyone who called us who needed an appointment, we saw them. But of course, we would see patients from within that primary care practice as well. But for us, managing our own schedule was important. Off to the left here, you see our director of behavioral health, our business manager, and Kayla Weiler in the middle is our manager in addiction medicine. The way we funded this service, Center of Excellence revenue was very important to us. Our care managers at the time were receiving $277 per patient per month. That's capitated, but it does require face-to-face contact. And then during COVID, mobile contact was allowable. But they provide psychosocial interventions, or they make sure people have access to psychosocial interventions, including harm reduction, as well as making sure they have a provider to prescribe buprenorphine. You can get paid fee-for-service from Medicaid, even if you're not their PCP. That's a very common misconception that I hear in Lancaster and also in Philadelphia. As far as I know, Medicaid is fee-for-service. So even if their PCP says Penn State Health, when we see them and we deliver Suboxone treatment, we do get reimbursed for that visit. And then the most important funding for us was this grant funding, this PACMAT, Pennsylvania Coordinated MAT grant. That really funded all of our salaries for this team to give us a starting point until we can see patients and generate some revenue to make it self-sustaining. Putting our phone number on billboards and buses and bus stops allowed calls to trickle in. We were not overwhelmed with calls. There was a lot of fear that that would happen, and we advertised very broadly, and we were not overwhelmed with calls. If you have a central phone number where someone can get help and you put it out there broadly, the lesson here is you'll be able to manage it. At least that was our experience. People can call this number and get an appointment, usually within 7 days, oftentimes same day or next day, at a location that made sense for them. And then during COVID, of course, we relied heavily on telemedicine. This was what we conceptualized. We thought this would be the ideal. Somebody calls us, they get an appointment very quickly. We stabilize them on buprenorphine. And then we wanted them to establish primary care in the practice and get that new patient appointment, even if it's a couple months down the road, and transition them into primary care. And that leaves our schedule available for more new patients. That's what we conceptualized. I will say it was a much harder process than that. It was usually a months or years long process trying to get people into primary care. We could talk about reasons why perhaps at the end when there's questions, but it didn't quite work as smoothly as we would have liked. But nonetheless, this was a very successful endeavor. This is how we conceptualized it, that we would go in and we would do this work. We would role model a way of treating patients. Providers, nurses, clinical support staff would be able to see this is not that hard, and maybe we would inspire them to do the work as well. We did find that these practices became more likely to screen for substance problems because they knew I was there Monday evening, for example. This is their Family Medicine East Petersburg. I made all of our team members take photos of themselves, even if they didn't want to. So you're going to meet our team today in photos, whether they like it or not. This is in the middle, one of our nurses at Family Medicine East Petersburg. That was one of our most successful sites. And that was because the nurses would just wander over and say, what are you guys doing here? Tell me more about it. Here's a quick case study. I don't want to spend a lot of time on case studies, but this is the ideal. Was a 28-year-old woman who went to an STD clinic for a routine gynecologic complaint because she didn't have a PCP. At that visit, the provider learned that she just got out of rehab and she was craving opioids, but there was so much high barrier care. She really had as a person with a full-time job, she couldn't go to appointments every week. She couldn't adhere to the requirements of buprenorphine treatment in order to receive that important medication. So instead, she was purchasing it from an unsafe supply. And at this STD clinic, they referred her to us. We saw her within 2 days and we prescribed Suboxone. She actually did very well on 8 milligrams once daily. She established primary care at that mobile site. Her new PCP had never written a Suboxone prescription in her life, but she had a waiver and she knew the work was important. She just didn't know how to do it. And she took her on as a patient. She knew that we were still there Monday evening if things didn't go well, that this patient could return to us. That was really key. And I checked in on this patient recently just because I wanted to present this case study. And I learned actually that she did so well, she tapered off the medication. That's not typical, and that's not something that I think is necessary. But that's something the patient wanted to do, and she seems to have done pretty well with that. And now she's been married for a year and preparing to become pregnant with her first child. So that's an ideal. That's just one case, but that shows what we wanted to do and how it works. We are a safety net. Like I said, the providers were willing to take a leap and prescribe Suboxone because we're there and the person can return to us if it's not going well. And many times it doesn't go well because the patient might be using other drugs and they might be missing multiple appointments. They might continue to use opioids while they're taking Suboxone, or they might not be adhering to the dose recommended by their provider. The care manager who's alongside us to meet the patient at that first appointment with the provider remains a resource for the patient and the practice when they transition to primary care. So the care manager guides them back to us. Off to the right here is our care manager, Kenny. And that's at one of our family medicine practices, Manor Ridge. Kenny works with me on Thursday afternoon, and when our patients don't show up, Kenny and I solve all the world's problems. I really like working with them. So here's another quick case study, a person with a methamphetamine problem who needs a safety net. She was receiving Suboxone 8 milligrams from her PCP. Prior to starting Suboxone, she was snorting tablets that she believed to be oxycodone. In reality, they were probably fentanyl. She was missing a lot of appointments. She never wanted to provide a urine test. When she did provide a urine test, it revealed methamphetamine. Her primary care provider felt that she needed a higher level of care. This is reasonable. She's missing a lot of appointments. What she needed was lower barrier care, which was very labor intensive in her case. So that's the point of this case. Low barrier care does not mean just give them a prescription and move on. It's actually this particular patient, I changed her name so she has some anonymity, but our team interacted with her probably 10 to 15 times per month. Because she was so prone to losing prescriptions, running out of medication before she could get her next refill. And she had a real serious methamphetamine problem where she wanted to stop and she was not able. Really, a lot of work with this patient. What we learned is she did have ADHD. She needed treatment for ADHD. And she did have a very high tolerance to opioids. She needed a dose of Suboxone 32 milligrams per day. And you can't give her 120 films in 1 month. She cannot manage that. But she does do well now if you're treating her ADHD and you give her 60 Suboxone film with 3 refills and see her every 2 months. She does very well with that. So this is somebody who started in primary care, was referred to our team, and now is back in primary care and is doing well. And there's a management plan that works for her. A lot of the practices where we did our work were concerned about patients within their practice who were taking opioids for pain, usually in high doses and for a very long time. Some of the interest of having us in the practices was that concern exactly. So we were always willing to see patients in these practices, even if they didn't seem to have an addiction problem, just because they were taking opioids for pain. And we did observe a lot of instances where providers did misinterpret CDC guidelines. They thought they should be tapering patients down to 90 MMEs per day, even though the patient wasn't having any problems at a higher dose. So that was a very common thing we saw. And we felt it was very important when we saw these patients to give that feedback to the providers that that's not what the CDC guidelines say. Of course, tapering opioids when somebody's been taking them for a very long time is not the same as never having an opioid prescribed to them in the first place. And that's the point of this article. That may be a word-for-word quote, so I want to credit this article about inherited patients taking opioids for chronic pain. And this article summarizes a few different cohort studies which show that periods of opioid tapering are associated with increased risk of fatal overdose and completed suicide. This was a big problem in our health system where patients were being involuntarily tapered off of their opioids. And it was without the providers had the best intentions, but it was contributing to increased risk of overdoses since many of these patients would seek out an unsafe supply. So here's an example of a patient, Ken, not his real name. He's 68 years old. He was receiving Dilaudid tablets for several years for knee pain. Even if after he had a knee replacement that seemed to be fine from the orthopedic doctor's standpoint, he still needed this hydromorphone. So they asked us to see him. They said he's on hydromorphone for a very long time. Is that a problem? We met with him. We asked him about his hydromorphone. How is it helping him? Is it hurting him? We talked to him about addiction. We talked to him about Suboxone treatment, but we agreed. You think this medicine's helping you? It seems like it is. Nobody should take that medicine away from you. These visits, from our perspective, are not intense fact-finding missions. We don't comb through the PDMP and point out every small discrepancy, because that's not the point from our perspective. We need patients to have a very positive experience when they see us, particularly this type of patient. And he was surprised. I do a lot of these visits with Kenny, who I referenced before, and Kenny can attest that patients come into these visits very afraid of addiction medicine. And it's very important to us that they walk out happy and with a very positive experience from us. Because 2 years later, Ken called us. He didn't want to say why. He didn't even want the social worker in the room. But what we learned about Ken is that he did have a more extensive history with drugs in the past than he had let on at his appointment with us and his PCP. That's very common. His daughter died, and he found that he started taking more hydromorphone in the evening to help him sleep. He was very sad. And he figured out that if he crushed his hydromorphone and injected it, that his 1 month supply now would last longer, and he wouldn't run out before he could get his next refill and get sick. And then he saw us because he had track marks all over his arms, and it was going to be summer, and he needed to do something about that. He did very well on Suboxone. He since moved out of the state, and we reconnected him with a provider in a different state. But this is how we want those visits to work as well. I think the most important thing that we achieved, though, is to circle back around to low barrier care. We saw a real culture change in our health system. I'm going to really be careful. I'm not being critical of the way Suboxone treatment has been performed up to this point. We've been taught that what works is negative reinforcement. We actually learn that just through what we watch on television and how we see society handle addiction. And we're not taught about treating addiction in medical school. So it seems normal to us to enact sanctions and to have that be the thing that gets a person to change their behavior. And we've had a lifetime of seeing that, and that seems like what we should do. And a 4-hour course or an 8-hour course or even a 24-hour course is not going to change that. We have to always be very mindful that actually positive reinforcement is what works. And one thing about this is patients believe they need this too. Patients think they need negative reinforcement. So they think they need these sanctions. Actually, when I see patients for alcohol problems, they're always asking me to give them a medicine that's going to make them sick if they drink alcohol. Even though up to that point, they've experienced nothing but negative consequences from alcohol consumption. But they think that feeling flushed and nauseous from drinking is the thing that's going to help them. So the fact that patients say, yes, this is what I need, doesn't make it so. Keep that in mind, that patients need positive reinforcement. Even if they don't know it, we have to care about them until they can care about themselves. That's what research shows us. We're really confused about this in addiction medicine. I have some version of this slide that I present at new employee orientation for our nurses, and it always puts a stop to the conversation. Tara's the nurse who started with me when we started all this. We agreed very early on that we were never going to greet a patient with a urine cup. Never. If we needed a urine at that first visit, then it would slow us down, and we would explain to the patient why we needed that for diagnostic purposes. Many times we don't need it. These images are depicting two different ways that you can greet someone when they come in and ask you for help. But it's also depicting two different types of relationship that you can have with a patient. You can partner with them, or you can police them. You can't do both. It's not nuanced. There's two different relationships. It's just confusing if you try to do both. Someone who's been very influential on me and how I think about this and addiction is Shoshi Aronowitz. I don't know if she's in attendance today, but she wrote a great article. It's in Filter magazine in 2020 titled, "We Are Nurses, Not Police. The Methadone System Expects Otherwise." That should be a required reading for anyone who works in correctional medicine or addiction medicine. This is a real barrier to implementing buprenorphine treatment in primary care because it's so confusing. ASAM has a 55-page document about urine testing that notes page after page, there's no research, there's no research, there's no research, but they say you should do it to explore denial, motivation, and actual substance use behaviors. And that's another way of saying you should do this to see if your patients are lying to you. And they don't really explore why patients might be incentivized to lie to us. They just say you should do it for this reason, which is a way of saying patients are prone to lying to you. In surveys, one of the most common reasons why primary care providers don't treat opioid use disorders because they do not trust these patients. We have immense stigma, but we don't consider our role in causing it. There's also a lot of statements like this from the buprenorphine waiver training. Urine testing is a means for helping the provider to help the patient. They don't say how. There's no if-then statements. If this, then do that. They just say that to do the test, but they don't say how to use the results. So it becomes a canvas where providers can paint their own implicit biases. If you have a negative viewpoint of cannabis, you'll respond one way. If you don't, you'll respond differently. The way they ask us to implement it is also confusing. The buprenorphine training says it's not meant to catch the patient, but you should still do random and observed urine collection. But when you're doing it at random times and asking them to pee in front of a staff member, make sure it's convenient to the patient. This is all very confusing. And I think it just shows how our profession just doesn't know how to use this test. We should reconsider it altogether. I don't want to belabor this point, but this is a patient who had a urine drug test pretty much every month throughout the 2010s. Her urine drug tests and Epic go back to 2009. I didn't even know we had Epic in 2009. But the question to ask here is, what did we really learn about this patient? We didn't learn whether she was using fentanyl because the point of care test doesn't detect that. We also didn't learn whether she was taking her buprenorphine because there's very few confirmation tests being done. But mostly we should ask ourselves, is this person going to be treated the same way in the ER or when they have pain as somebody who does not have all these drug screens in their chart? Here's the way that I treat opioid use disorder. Analyzing body fluid is not a big part of it at all. A person wants to stop using drugs or cut back on using drugs to achieve something. It's a means to an end for them. So I always try to figure out what that is, what's their goal, and document and ask about it at every visit. Ask about their physical health. If you're prescribing the medicine and that's improving, that makes sense to me. That's how I treat everything in primary care. Ask about their mental well-being. Ask about important interpersonal relationships. This often brings people into treatment. They want to reconnect with their children. They want to see their nieces. And their family members won't allow them to be around the children while they're using drugs. You can ask about all these things, and this is how you can measure the success of this treatment. When you begin to treat addiction this way, then it makes sense to talk about harm reduction, because now it's not a binary positive or negative result on a urine test. Now you're truly spending 20 minutes looking at the whole person. And now you can understand why fentanyl test strips and syringe service programs make sense. And I'm very proud of this table. In our busiest family medicine practice in Columbia, our care manager, Amber, set up this table on Overdose Awareness Day in August last year. And people who are waiting to see the doctor or advanced practice provider for hypertension, diabetes, people who are bringing in their children for immunizations or a sore throat, they can walk up to the table and learn about syringe service programs. They can take Narcan. They can get fentanyl test strips. And you see these little paper candles. They were invited to write the name of someone who was important to them, who died of a drug overdose. You get to that point of having this table in the waiting room of a family medicine office when you really focus on treating psychosocial factors for the entirety of the appointment and seeing the whole person and not just their body fluid. Here's a photo of the table at the end of the day. Here's what we learned from this process. We thought we'd be at one location for a few months, and we usually stayed there for a few years or indefinitely. I'm going to be at Family Medicine Norlanco every Friday, probably for as long as I'm here at LG Health. But that's okay. Some practices they say, you're here to do it for us. And that is what it is. Maybe it'll change over time, but we let providers adopt this work at their own pace. We found that seeing chronic pain patients, people who use opioids for pain, is very worthwhile because we're a safety net for them. About 10% of them will develop a problem with opioids based on studies. And if they have a positive interaction with us, they'll call us when they need us. And then we found that low barrier care works for most patients. I would argue it probably works for all patients, but that seems to have worked very well for most. And many providers see how we're delivering care and they adopt it themselves. I've seen a lot less emphasis on urine drug testing within our health system, with a lot of positive benefits, more people willing to do the work. Just keep in mind, low barrier care is very labor intensive sometimes. It's low barrier care is not prescribing medicines and then moving on. This is how I would summarize our foundation, the Center of Excellence, where we did a lot of buprenorphine training. We had care managers connecting patients to these practices. And then we layered on top this mobile team to improve access and retention and to begin to introduce low barrier concepts. And now in 2023, like with Amber's table, we are really leaning into a culture change and eliminating stigma. I write articles in the Journal of LGH and other local newsletters because I really care about our community first. And then, national publications can come later if that's something that would be impactful. But let's start here. And this is our focus right now. Our care managers, when they see stigmatizing language on the chart, they remove it. And that's our focus now. We've really reached a very good point. Here's our results. Our mobile team usually treats about 25% of all buprenorphine patients in the health system. We started this about early 2020. You can see the number of people receiving buprenorphine within LG Health really took off in 2020, and we've had steady growth ever since. We treat nearly 1,000 people with buprenorphine in our primary care practices. 23 of them do this work. We usually have 70 to 80 active prescribers based on our dashboard. Our dashboard pulls this data from the PDMP. About half of current patients fill a prescription for 10 out of the last 12 months. That's a retrospective look at retention. It's not a true measure of treatment retention, but we see it as a sign that people are staying on this medication longer. And we think that's from our low barrier approach and our function as a safety net. This is external data from the Pennsylvania PDMP dashboard and overdose dashboard. We see in our county an increase in buprenorphine prescribing, particularly beginning in 2019, compared to the rest of Pennsylvania. And we've seen a linear reduction in overdose deaths over the past 8 years compared to the rest of the state, where there's still a linear increase. And here are overdose deaths in our county. 2023 is on track to be the lowest number of overdose deaths in almost 10 years. And we're not solely responsible for this. I'm not saying we are, but we are such a large system. We're the largest in our county by far. I do think that we're impacting these numbers in a major way. This is the impact of our Center of Excellence and traditional buprenorphine treatment, very impactful. This is when our mobile treatment initiative started, and now we're really leaning into culture change. These are all the practices now at LGH where a person can receive buprenorphine treatment. This quote, I'm not saying that we're changing the world. The point of this quote, hopefully the point of this presentation, is a small number of people can really have a big impact. We don't need to wait for several thousand member professional society to start doing things differently. If we practice in good faith, we prescribe in good faith, and we keep the best interests of patients in mind, we just need a small number of people to spread the word and role model a different way of treating this in primary care practices. You don't have to go to 9 different places the way we did, but take 3 people, go into a practice where they have extra exam rooms and where they're not doing this work, and see what happens. That's what I would recommend. These are some of my references. That's my presentation. It's the first time I've given it, so thank you for your attention.
John, that was really, really just so inspirational. And, you know, I'm not a primary care doctor, but I have some primary care heroes. Now I have a new primary care hero. So thank you. That was really, really wonderful. I have some questions, but I'd love to defer to the team. I see Peggy clapping, and I know everyone was touched in the same way as I am. You really, you know, hit on some things that don't come up in our conversation that often. I'd just love to hear from anyone else before I launch in with a few thoughts. All right, I'll ask a question.
I always say if there's no questions, I'll take that as a compliment.
Yes, yeah. Well, I have lots of questions, but more because, you know, we've tried to implement, you know, ED bupe prescribing in emergency departments that think they want to do it, and then they, you know, they also come up with a lot of barriers. And we, you know, we kind of do this one-time road show, and then we send some emails afterwards. But I think for me, a lot of what you did is being there consistently, you know, in a way that, you know, is hard to arrange. I mean, this means you cleared your schedule, you were there all the, you know, it sort of is a huge shift in practice. And I'm sure that's part of the success, but I'm just wondering logistically, how did you clear everyone's schedule to be able to do all that all the time? I mean, the grants, did you know what
Yeah,
you
the
were going to do
grant, I
with the
mean,
grant?
yeah, the grant was, it paid all of our salaries for a year.
But
And
it
so,
was it to pay you wherever you practiced and you were able to mobilize it, or?
I mean, the grant, they wanted deliverables. They wanted to know how we were using the money, and we used it for salaries for providers, nurses, care managers. And then from the practices standpoint, there was oftentimes vacancies. Like we have such a shortage of family doctors, so they have space that's not being used. So of course the health system wants that space utilized as well. So there's a lot of mutual incentive for us to be there. You have to get credentialed at these sites. And I will say, I mean, I'm so proud of our team because it's not always comfortable. I mean, everyone's professional, but we're going into a practice that's not our own. And there's some wariness on the part of the practice. And then sometimes they do hire more clinicians. And now we get there and there's no rooms for us. And what we do, we think is important, but it is their practice. And so there are a lot of hiccups like that that need to be worked out, and hurt feelings at times that you have to.
I'm always impressed in the ER with the traveling nurses who can just like show up in chaos and, you know, have this certain kind of personality that, you know, just flies right through it.
Yeah, we do reimburse mileage. I mean, we reimburse mileage with these positions. We don't have any grant funding now. We have a cost center, we have a budget, we exceed budget expectations. I don't know if we're revenue positive on a whole, but they tell us their expectations and we exceed that by about 20%. So we're doing okay.
And I have another question. Feel free to interrupt me, folks. I thought the centers of excellence billing were going away, but how much is like an office visit? Because
So now
you
it
mentioned
used to be a flat 277 capitation per patient per month, so long as you were interacting with them. And now they said managed care organizations can negotiate that. And many of them are going to value-based payment systems. So I honestly don't know what it is now. It might differ per organization, but all of the managed care organizations with Medicaid still provide it. I just don't know what that payment is now.
My understanding is that 275 per member per month went away, but that was the care manager, so that's gone away. I think it's been replaced with a very small number.
Yeah, the medication management visit is 99, you know, an evaluation and management code. Reimbursed by Medicaid, which is a lot less than commercial insurance, but still, it's not nothing. And I just want to dispel the misconception that you need to be their primary care provider in order to get that reimbursement. That's not true. We haven't found that to be true.
And then
oh, sorry,
yeah,
Jimmy.
go ahead, Ashish.
Hey, hey, John, thanks for a great presentation. I learned a lot and definitely inspiring. I had a question about this kind of whole topic because I do integrated primary care and addiction here in Philly. I still think the Penn clinics here downtown, patients have to be within have a Penn primary care provider to join their MOUD program. I don't know if that's because of misconception or other reasons, but I've been told that repeatedly. So that's something we can follow up on ourselves. My question for you was about whether you considered a model with a that would be like a dedicated home for substance use disorder patients. So like an
Well, we
addiction
have that
clinic.
now, and I should have included that in the
Oh, maybe I missed
presentation. But
that.
yeah,
Okay.
we now have consolidated a lot of these mobile sites into a central practice site that's co-located with psychiatry. So
Oh, wow.
we still have maybe 4 mobile clinics right now, and those are always in flux. We're actually in the process of shutting 2 down, turning patients over to the practices. And then some elements of our mobile team that I haven't discussed, like we have a lot of practices where there's only one provider and none of the other providers want to be involved. And we've had times where that provider goes on medical leave and our mobile team then goes out there to
Yeah.
be a
So
safety net.
for that co-located clinic, are you guys making enough reimbursement to keep the lights on and pay everyone?
Well, so I would say, I mean, I'm not responsible for the business side of it, but I will say that this mobile model, because you're making use of resources that are already there. I mean, you have exam rooms that
Yeah.
are not being
Right.
used.
Right.
So you are making it's cost effective that way,
Yeah.
and it allows you to build. And we built, and I showed you the number of patients being treated. It kept going up
Right.
until it made sense financially to now have a central location, because that's not something we would have been able to justify probably in 2020. But in 2023, we can say, look, we know we're going to have 25 new patients per month, and we know we're going to have this many medication management visits per month. So starting this way provided some validation that there's enough demand, there's enough need for this to make that investment in a central location. In our case, it's co-located with psychiatry, so it's not our own building, but it makes sense since so many of our patients have co-occurring mental illness. So yeah, we do have that now, and I should have included that in the presentation. But we had to justify getting there, and this mobile model got us there.
Makes sense.
It seems so well thought out, but obviously you had to improvise along the way to make it work, which, you know, is really, it's kind of gutsy, you know, to try this and then expand. It's really impressive. I think that narratives in this talk are really helpful and very, you know, I think illustrative of, you know, your points about, you know, complex care. One thing that I see our group do, and maybe you have this internally and might be a good thing to share, is just, you know, on an email or a group chat, we do share our challenges. You know, I have a patient who has this, what would you do? And I'm sure you have some form of that, but I think that's something that the practices, you know, may also feel like, you know, you don't have to pick up the phone and schedule time with someone if the group is big enough to just send out an email. And I mean, you
We
probably do that,
we
but it
have
might
that.
be
We
interesting
have
to
a
integrate
listserv.
that in the
Actually, the
talk, a
listserv
listserv.
is one way
Mhm,
that we really try to also influence practice.
mhm,
Just I mean, it's my opinion. I mean, everyone has opinions, but you know, if we have skepticism around urine drug testing and we see that as a barrier, then we'll put articles out there that say maybe this isn't helping people as much as we think. So
mhm.
that's worked that way as well. It's been a way to influence practice towards an evidence-based
Yeah,
direction.
it seems casual, but it seems, in speaking to you, much more carefully plotted out.
Yeah, well, I will say some aspects, this mobile treatment, um, it was the only way for us to see patients because we didn't have a central practice site.
Mhm.
So some of it was
See,
born out of
I
necessity.
see, necessity,
Yeah,
yeah.
so if it
Wi-
seems well thought out, that's a post hoc rationalization.
Well, I mean, it's beautiful with the overdoses going down in the county. I mean, that's just, you know,
Yeah,
perfect
and again, I'm
example.
not saying we're the only reason for that. I'm really not. And there's a lot of work being done, but I will say we're very ubiquitous. There's only 10 of us, and
Mhm,
we really are everywhere.
mhm,
And we connect with our harm reduction coalition. Melinda Zip is at the table on every task force and work group, and that just wasn't the case 5 years ago. And I
mhm.
think that is very impactful.
Yeah, Fabulous. Is any component of this done as walk-in care, or are you really planning the appointments and you know how many
People do have to
patients you're
call
seeing?
us. Yeah, I will say in our mobile sites, like if there's a patient seeing one of the primary care providers in withdrawal, of course, we're going to see them. You know, you just say, send them over here and we'll put them on our schedule and we'll fit them in.
Hmm.
But we do want people to call that number.
Hmm.
It's kind of like your warm line. They
Hmm.
can call and get an appointment quickly. I will say too, as far as this mobile treatment began early 2020, and telemedicine did kind of uh, take away some of that need to be so
Hmm.
mobile, because
Hmm.
more than at least 50% of our visits are telemedicine.
I was going to ask you that. Do you convert no-shows to telemedicine? I know that's what Cooper does. If somebody
Well, yeah,
is,
if they can't make it in, yeah, we
Mhm.
think telemedicine is really best for our most vulnerable patients. We have
Mhm.
patients that are very transient. And
Mhm.
of course, they can bounce in between different practices. But also, that's been really crucial for keeping people in treatment. So yeah, we make liberal use of telemedicine. We really need that flexibility to stay.
Yeah, yeah. Other folks? I really think you need to write all this up. There is so much implementation, theorization, and people who have tried to bring more of this to primary care. I mean, maybe you have a closed system, and so it worked better. You had the funding, everything aligned, but it really tells a great story. And then with your philosophy and compassion behind it, it's really compelling. Um, so I don't know. I would endorse getting it out there in some form or another. It's really just so well done, and it's just more testimonial to the value of addiction care, medication, in this kind of setting. So I definitely think that's wonderful to you and your whole team, because I know it's not just you, and you're the first to admit it. But nice to have all the other people on the call, and really, I learned a lot, and it's really admirable. I think we might have to call you offline to figure out. We were really trying to create some sort of walk-in structure, and not necessarily walk-in as the most important thing, but we just don't have a lot of space where we can, create it. So we either need to make new space, which is very hard to do, or carve it out of existing places. But
One thing
it
I
seems.
wanted to mention too, one thing that's very rewarding is we'll see patients, say, Family Medicine East Petersburg, even if they've been dismissed from that practice from
Mhm.
primary care because of behaviors related to having an untreated addiction problem. Like they can come in and see us because we manage our own schedule. And then
Mhm.
our care managers work with the practice manager to get them reinstated. That's been
Mhm.
just so rewarding to see that.
Mhm.
All of our care managers are on here. They're very humble, they're very shy. But Emily Babico's on here, and she's been with our team even before I got here. And the work they do in all these primary care practices is really crucial to the culture change that I described. Amber McCompsey, Kenny Cox.
Yeah, fabulous team. Great work. And it's gratifying. And like I said, we all face similar challenges, so we can take some pieces of what you learned. Even the chronic pain narratives were super helpful, because, like you said, we have learned more of a police and punish approach, especially to that population, and that's just been really challenging for them. And
Some patients switch to buprenorphine because they have such problems at the pharmacy around their
Oh
oxycodone.
yeah.
We see a lot of that. In 20 years, I've never seen so much fear and misunderstanding around prescribing opioids for pain as I do right now.
Yeah, yeah, that's definitely been the shift. Well, thank you everybody for joining. Thank you especially, John, for putting this together, and Natasha for coordinating the timing. I really appreciate it, and I feel like I learned a lot and have a even really a new approach for some things. And we're going to tap you for
Thank you. I'd be
our
happy to work
creating
with
it.
someone because I'm not writing things up is not my wheelhouse. I like to write, but scientific papers is not my wheelhouse. So I'd be happy to work with someone in attendance on that too.
Great. So this was recorded,